Welcome, everybody. Today we've got a jam-packed webinar for you. It's scheduled to go about 90 minutes, and then we'll do some Q&A towards the end. I'm Dr. Steve Kraus. I'll be your speaker and presenter today. We'll be going over AOMSI ligament injury measurement analysis, as well as impairment ratings across the 5th, 6th editions with the AMA guides. So obviously in 90 minutes, that's a lot to pack into all of that. This is brought to you by Chirosight Digital X-ray Solutions. My background is over 36 years of being a chiropractor. I'm located here in Iowa. I've been certified as an independent examiner for impairment ratings for a number of years. The various editions going all the way back to the 3rd edition back in the early 90s to today, the 2024 edition of the 6th. And that's what we're going to share with you, a lot of new interesting insights. With my background of owning a variety of different clinics, I've testified in court over 30 times, done over 90 depositions, created hundreds of impairment ratings. So we'll be going over those experiences and the facts of how the AMA guides apply to your impairment rating. So I do need to do the usual disclaimer. None of the opinions that you're going to see here in this webinar today are of the AMA. It's my opinions, it's my information sharing with you. I'm not representing any other third party. So I'm not representing positions of the AMA, the ABIME, where I'm certified, or the AMA. And the conflict of interest is I've got ownership in a digital X-ray manufacturing business. My recommendation also is that for detailed information, you should purchase the AMA guides, and the digital version gives you access to the 5th, 6th, and all of the versions of the 6th edition that are out there. I highly recommend going to the AMA Guides website to go do that, and that'll help you tremendously. So we are going to be talking about a variety of subjects today. I'm going to explain how evidence-based practice goes into the AMA guides. We're going to go over a high-level impairment rating overview, and then we're going to dive into some of the details about MMI. I'm going to show you how to actually perform the AOI measurements yourself, the MSI measurements, how to apply that to the flexion extension views. And then we're going to actually do impairment ratings with the 5th and 6th edition and show you how to, from a high level simplistic point of view, to perform that, incorporating AOMSI as part of that. And then we're going to go over the narrative report, what you all need in your AOMSI ligament injury report, but then what you need in the narrative report, the overarching report. So let's start off with the evidence-based practice three-legged stool. The reason why this is critical is because it all carries over into AOMSI. Your evidence-based practice requires the best research evidence, which is the AMA guides. It's also their references. So their big one is Punjabi and White. They use clinical biomechanics of the spine as their major reference when determining angulation and translation. And then the guidebooks themselves, they have a variety of references in here, and they're considered the gold standard when it comes to impairment ratings. So your access to these various research evidence is important, that you know the resources and the references. And then it comes to patient values. What if a patient doesn't want to continue with certain treatment recommendations? What if a patient is eligible for a surgical fusion, but they don't want to have that? Can you still do an impairment rating on them? And we're going to go over that today. And so the patient preferences are allowed. They're important. It's part of the evidence-based practice, and it is part of the AMA guides. And then, of course, your clinical expertise, all the cases you've seen over the years, all of the measurements and impairment ratings you may have done in the past, or just your clinical expertise on how patients recover from auto injuries. That clinical experience is extremely important when it comes to your narrative report. So, the true definition of evidence-based practice started way back with Sackett, actually in the late 90s, but he updated his definition about 23 years ago. And quite frankly, it's taking all three legs of the stool equally. The published literature doesn't hold any higher rank over patient preferences or over your clinical expertise. They're all three legs of the stool, and if you take any leg out, the stool falls over. So it's important when you're making your conclusions and you're drafting your narrative report that you've included your expertise, you've taken into account the patient's preferences, and you're using the scientific literature. So let's apply that now to impairment ratings. So as you all know, there's the fifth and sixth editions as the recent levels. There are a few states out there where their workers' compensation still uses the fourth edition. Nobody uses the third, and quite frankly, nobody really uses the fourth to any significant level unless it's a work compensation type case. But for the most part, everybody's using the fifth or the sixth, with the majority using the sixth when you're talking about independent medical reviews. So, what about the attorney? So, after all, if there's going to be a legal settlement from a car accident case, it's really, how is the attorney going to use your report? How are they going to use the impairment rating to settle the case? So let's look at it from a second of who's all looking at your report. And remember, there's kind of two reports we're talking about. We're talking about the AOMSI ligament injury report, which is focused on one specific piece of an impairment rating. And then there's the overall case, the narrative, where you're summarizing things like the mechanism of injury, the history, the exam findings, any other tests that are relevant. And then you're mentioning the findings from the AMSI report, which is attached as a compendium to your overall report. But all these people see this report. So the report has to be drafted in such a manner that they could understand it, they could read it. It should not require further explanation from you if it's well written. So an example of an AOMSI ligament injury report might have a cover page where it summarizes all the findings, the measurements, the outcome, your impressions, just like a standard radiology report would. And you have that in a one-page component. But your supplemental pages might be the exact measurements, how you arrived at those measurements, what was the method, what's your resources, was it a rateable or abnormal finding? And then you might do an analysis. You don't have to do all these things, but this would be supplemental information of where you're graphically showing how a certain motion segment, let's say it's the C, in this case, the C3, C4, and the C5, C6 motion segments are significantly affected, and you're highlighting those in a graphical form. So it's part of your computer aided analysis using an algorithm. And we'll come back to that language that I just used because it's important from a billing perspective. So today we're going to focus on the cervical spine. We've got 90 minutes, and there truly is going to be a dozen, if not dozens of nuggets I'm going to share with you today that I'm going to guesstimate that 90% of you have not heard before. And it's because of some of the updates that have occurred. So you can apply these principles that I'm going to go over with you in the cervical spine to the thoracic or the lumbar spine as well. So when we refer to the impairment ratings, we're going to use the fifth and sixth edition. But in using these textbooks, you can now get these in a digital format. The entire book is digital on the AMA Guides website. And I don't recall the exact price, but let's call it 260 bucks. Maybe it's 300 bucks. Unfortunately, that's annual. It gives you an annual subscription to all the prior editions, the fourth, fifth, the sixth, and all the updates that have occurred to the sixth. There's actually been updates over the last 4 years, every year to the sixth edition, because it's the most recent. And the biggest update that has occurred is the 2024 edition that came out in December, just 6 months ago. And this version is only available digitally. There's not a book that you can go buy. But again, the nice thing is by subscribing to the digital AMA guides, you get this and all the other ones. So we're going to share some information that's going to be a little controversial. It's going to be a little, I don't want to call it disappointing, but it's going to be an eye opener for some of you who have been doing this for quite a while. And the significant changes that have occurred in the 6 2024 edition are important, and we're going to cover those here. So, what edition should you use? Well, as you can see on these tiles, certain states for worker comp injuries, the legislature in those various states have listed what is the authority. So there's a number of states that require the fifth. There's a number of states that require the sixth. So if it requires the sixth, it means you can't use the fifth or fourth if it's a work comp. Now, when it comes to personal injury, virtually all states do not have specific rules when it comes to personal injury. So most states, you could still use the fifth edition even though your work comp requires the sixth, depending on the language. There's a few states, and what I would recommend you do, go ahead and go to Chat GPT if you can trust it, and see what your state is. You know, I assembled this list a couple of years ago, and I admit, you know, if any legislative changes have occurred in your state over the last few years, it may not be current on what states, you know, you know, in terms of looking at what law and what rule your state requires. But again, for personal injury, it's often up to you. But I'll leave you with this comment. Imagine yourself in a deposition and the defense attorney asks you this question. Doctor, why did you choose the fifth edition and not the most current sixth edition? There are plenty of good examples and good answers to that question. We'll cover that in a little bit here, but you need to be prepared for that answer. If you're choosing to use an older version, the answer may be as simple as our jurisdiction requires it. Now, the attorney might say, well, it doesn't require it for personal injury cases. This case, it requires it for work comp. This is not a work comp case. Be prepared for the follow-up question. I know we have a number of attorneys on this call, on this webinar today, because I noticed on the registration list, a number of attorneys signed up for this. So the AMA guides, it is not only a set of definitions, but it's a set of rules to follow. And that means we don't deviate from the rules. You can't make up your own rules. I've attended some webinars and I've seen a number of individuals make their own assertion or their own um, left angle away from the rules, and the guides don't allow that. So if you're going to provide an impairment rating, you are required to follow the rules. Yes, there are numerous places within the guides that allow for exceptions, that allow for your clinical experience to add, subtract, or go down a different path, but they define what those exceptions are, and you are required to document in your notes why you deviated. And is that even allowed? Because in certain areas, there is no exceptions. And when it comes to AOMSI, I'm going to tell you right now, there is no exception to the measurements. And we'll talk about that coming up here. So what about the guides within personal injury? Let's be clear, folks. The AMA is not shy in the guides saying what's the purpose of the guides. And the purpose is clear. It is to arrive at a numerical number to determine a monetary value. So it's not just for kicks and documentation on a loss of function that a person might have. It is clearly to give the state of residence of that individual. It's to give the attorneys and the legal system or the work comp system, it's giving them a number so they can come to a monetary award. So that is what it's for, so that you don't have to shy around it. So when you're in deposition, what's the purpose of all this? It's crystal clear what the purpose is. The AMA guides lists it out, and you're going to arrive at a whole person impairment. Well, what I'm seeing happen out there in our profession, I'm seeing a number of individuals who list the various body regions and put an impairment, but they don't do the combining to arrive at the whole person. They're not doing a regional impairment, and then it goes up and results in a whole person impairment. You need to arrive at a whole person impairment in the end. And you can state that you assessed the cervical spine. You can state that. Let's say they had a shoulder injury. Are you doing an impairment rating on the shoulder injury? What if they had a knee injured from hitting the dashboard and the knee is still having problems, but it's not of a surgical nature? Did you do range of motion? Did you do a knee evaluation? Are you going to add that impairment if it exists? If you're not, you need to address it and state why. So today's focus is not the knee, it's not the shoulder. Our focus today, because of our time, is we're going to focus on AOMSI and the cervical spine, as well as overall impairment of the cervical spine. So you can come up with a whole person impairment rating for the cervical spine. So there's two methods that the guides clearly state are acceptable methods for determining AOMSI: the angulation method and the relative translation method. Some of you who have been doing this for a while might notice the word relative is present in front of the word translation, because relative translation is different than the older method of linear translation. Linear meaning just a straight up millimeter measurement. These two methods are the most scientific methods, but they do allow for the linear method in the 5th edition. And so when you do the measurements on the actual x-rays, on flexion and extension for translation, you will arrive at certain percentages. Or if you use the older method, linear, you'll have a millimeter methodology that you're going to report on for each motion segment between C3 and C7. You'll start up at C2, but angulation is for C3 to C7, and we're going to show you how to do the points in some slides coming up here. But I want to talk to you first about the importance of these measurements. And when do you do these measurements? Well, the AMA impairment rating reports are critical because they provide a framework. so that you can determine a permanent impairment. So remember that there's no such thing as a pre-permanent impairment rating or an impairment rating that isn't permanent. The impairment rating is permanent. It's the whole focus of it. Here's where they're at. They have a permanent impairment rating. And you must be at MMI when you handle that. But let's talk a little bit about some of these updates that have changed the landscape for AOMSI. So as I mentioned earlier, in December of 2024, the sixth edition was updated. And why did they do it? So these words on these 4 bullet points that I have here for you came straight out of the mouth of the authors. I attended a virtual lecture by the authors when they presented these changes. And these are the words they used. They said they updated this because of outdated methods. There was too much subjectivity. There was inconsistent results, poor reproducibility between intra and inter-rater reliability. And they said they were getting doctors, lawyers, and judges all asking for clarity on certain areas. So as you see on the far left, there's 17 different chapters in the guides. And specifically in December 2024, they made changes to chapters 15, 16, and 17. So the 2024 sixth edition was evaluated and a study was published on the advancements of this new edition. And the study said there was improved reliability and it's a lot easier to use. I'm going to share with you, it is definitely much, much easier to use, way less complicated than the prior 2008 sixth edition. So in summary, the AMA authors, the guides authors, their subcommittees, their position is this. The original 2008 sixth edition is established and they didn't change, more than 10, 20% of this book here. The foundation of the sixth edition is still all there. So it's not like it's a whole brand new textbook. The 2008 version is still pretty standard. However, when it comes to determining impairment ratings for the spine and the upper and lower extremities, it did change the methodology of doing that. And we're going to cover that here today. So with the focus of the 2024 on 15, 16, and 17, they opened it up quite a bit. As a matter of fact, you had the opportunity to attend all the meetings virtually. I attended some of these meetings and you could give feedback. So they opened this up not to a small group of editors and subcommittees. Yes, there's dozens and dozens of contributors, but they opened this up and it's open to chiropractors as well. So what are the key things to take away from this? Well, currently the sixth edition is the standard in 40 different states and countries. So it is considered the gold standard using the sixth edition. It doesn't mean you can't use the fifth. I'm just telling you, states and jurisdictions are adopting this sixth edition. My recommendation again is you need to subscribe to this because it's digital only to get your hands on the information. But the benefit of subscribing digitally is you get access to all the prior editions, the full book. And you can download much of this, and the graphs and charts and tables are all there for you. I wanted to share just a little side note with you that the 2 main authors of the musculoskeletal chapters 15, 16, and 17, and 17 is what we're going to go over today. But one of them happens to be a chiropractor, an MD-DC out of Canada. So I'm going to share some other things with you. That chiropractors are listed in here. So you're certainly allowed as a chiropractor to perform the spinal impairment rating. So let's talk about what is impairment versus disability so that we don't confuse the two, because the AMA guides specifically focuses on impairment, which is defined as a significant deviation or loss of any body structure or function. It could be from a health condition, it could be from a disease, from an injury, but it's distinctly different than disability. And disability really focuses on activities, participation at work, socially, even at home. Um, Disability can involve personal, environmental, workspace. Disability really is a complex interaction of health conditions. It involves mental uh, health. It involves personal factors. The AMA guides is not going into that at all. And that's not what you're doing with an impairment rating at all. So let's be clear that the difference between these two things is clearly a function. A loss of function is what we are talking about for impairment. And for us, it's loss of function of the cervical spine. So this is an example of a couple who didn't have a good relationship. The man's picture, the woman bit off the middle finger, had strong teeth, and broke the bone. So the middle finger's cut. Is this injury rateable? Yes, it is. There's an amputation, and there is a permanent impairment here that you do on the finger. And then you bring that up to the hand, and then eventually the whole upper extremity, and then it converts to a whole person impairment. So in this particular case, this individual was a consultant. So they weren't a laborer, they weren't a pianist, they didn't type at a computer. The kind of consulting they did was mostly verbal. So the question is, while there's a significant impairment here, is there a disability? Does this person have a disability? They lost a finger, for crying out loud. Well, the disability is virtually zero. And there'll be a small little disability, but virtually zero, because their occupation wasn't affected. Now, let's say they suffered from embarrassment, and every time the person goes out in public, they have a major problem that their finger is visibly missing, and now they have psychosocial adaptation issues. Okay, this plays into disability. This plays into some other components. So now, but what if the person fills out all the questionnaires and the person has one of those attitudes of, I don't care, no big deal. They may have little to no disability from something such as this. So the role of our impairment ratings in accordance with the AMA guides, and let's make one thing clear. AMA guides is really the only place you do impairment ratings. It's the only source for it. Countries from all over the world use the AMA guides. Now, there are other things when it comes to personal injury in rating the severity of an injury, such as, you have the Quebec Task Force. You have all these, you have the Croft and Foreman guidelines. That's not what we're talking about here. Those are uh, a different kind of rating. You notice they're not impairment ratings. They are trying to gauge a severity level. Impairment ratings come up with an actual percentage. And what is 100% impairment? It means you're in a coffin, you're dead, you're not even breathing. 99% means, you are in a complete coma. So certain body regions have maximum impairment ratings. For example, we'll find out that the cervical spine, you can never, ever go above 33%. It's not allowed. I mean, think about it. So we're not taking into account disability at all. I just want to drive that point home to everybody is we are clearly looking at a loss of function. And one way that the AMA has been able to keep the guides current is they have an AMA Guides newsletter. Now, I've gone all the way back to the year 2000, might have been 2001, with these AMA Guides newsletters. And there's normally just 6 newsletters a year. Sometimes I do 7. And the majority of the times, these newsletters are talking about certain organ dysfunction. It might be a cardiovascular impairment. It might be impairment on the lungs. It might be renal failure updates or better ways to analyze it, case studies, things like that. And then, so in some years, there's not even a single spine issue. Then in some years, there's 2 of them out of the 6 newsletters. So I went back for 25 years and reviewed every single newsletter and looked at every single one that dealt with the spine. And to my surprise, even back in 2019, the AMA Guides newsletter talked about changes or errors. I'm going to say that again, errors. They use the term errata in the 5th edition, as well as the 2008 6th edition. And they made corrections to those, corrections to the diagram, to the measurement. But here's the thing. They don't print the 5th edition anymore, right? They're not printing that 5th edition. If they've got a warehouse full of some old books that you could buy, maybe they still sell you the book, but for the most part, you're going to get it digitally at this point, or you're buying somebody's old book, which may have the errors in them. So I drafted a paper. So if you look in your top right corner here today and hover over materials, that's right next to the settings. And there's 2 materials I uploaded for you. One is a white paper that I wrote, and it talks about the changes to the 2024 6th edition, as well as I quoted some of the changes from the newsletters. And the AMA states the newsletter is considered part of the guides. So changes they make in the newsletter to keep it up to date is considered just as valid as the books, the textbooks themselves. So I wanted you to be aware of that. And there's a separate subscription you can use to get access to those. I think that's another $300 a year. But anyway, I've done the work for you on that one. Uh, so let's move on here and start diving into the nitty gritty of why we're here today. So the 6th edition, even since 2008, talks about diagnosis-based impairment, DBI, which is different than the 5th edition. Um, Here, they put all of the emphasis on the diagnosis. So when you perform an impairment rating, it's extremely important. There's 3 areas: the clinical history, the physical exam, and relevant clinical studies. Such that when we say studies, we're talking about diagnostic studies. So that could be X-ray for AOMSI. It could be a nerve conduction velocity test. It could be an MRI. And then the overall diagnosis. So you have to arrive at the accurate diagnosis. Do they have radiculopathy? Uh, is this just a cervical strain? You know, what is this? And your diagnosis is critical because you're going to use the diagnosis to determine the impairment rating. So who can do this impairment rating? Well, this language is straight out of the textbook, the AMA guides, and they actually use the word chiropractic. They say chiropractic medicine. So the guides is for allopathic, osteopathic, chiropractic medicine to perform permanent impairment. You notice they didn't say physical therapists. So what is your responsibility? You're supposed to provide an unbiased assessment. Now, I'm a certified independent examiner, So we've all heard of IMEs, right? So oftentimes your patient is going to be referred to an independent examiner, and they might perform the impairment rating. Are you allowed to perform the impairment rating as the treating physician? You certainly are. You can do it. Just make sure that you're remaining objective and that you're not going to get accused of trying to favor the outcome towards your patient. Stay objective. And in doing so, I can tell you with my 90 plus depositions and hundreds of reports that I've done over the years, I can tell you a couple of times in a deposition, once in the courtroom, uh, the defense attorney started to go down that line, but it's easily handled. I followed the guides. Uh, I didn't deviate from the instructions of the guides. It's standard. I follow the standard. Uh, and then I shouldn't say your attorney, but the patient's attorney is going to ask you, did you lean towards the benefit of the patient? No, I applied the guides to this case and it's handled. So I've never seen a situation where it backfired. So you can certainly do this as the treating physician. So we need to understand a few terms though. You're going to do an impairment evaluation. Well, you're going to use standardized methods and you're going to follow the rules of the guides. You're going to come up with a percentage and you're not an independent medical evaluator when you do it on your, even though I'm a certified uh, medical evaluator, the term should not be used when you're doing it on your own patient. So when do you do the impairment rating? This is a critical component, folks. At MMI, we've all heard of maximum medical improvement. Well, that term is a status, okay? It's a status of the patient. When is that status achieved? Well, this comes back to evidence-based practice, your clinical experience, your physical exam. Uh, when has the patient essentially come to a status where they're really not getting any better of any significance with care? They've plateaued in their recovery. They're not getting worse or better. They might have a few ups and downs of a very, very minor degree, but for the most part, they've flatlined on their recovery. Now, on this slide, it says beyond 12 months. That was used by guide language. That if you read the sentence carefully, they're not saying it automatically happens at 12 months. This could happen at 6 months. It could happen at 3 months. Okay? Like the guy with the finger chopped off. Well, that could happen in 1 week. Okay? Uh, because that's all that happened. No other injuries, no neck injury, no wrist injury, just the finger got chopped off. Okay. And you could arrive, and then let's say you want to wait a while for psychosocial adaptation. You fill out questionnaires, you conduct a good history, you see if any other functional deficits exist, and you could perform that impairment rating, right away. So when are they truly at MMI? Well, I am seeing out there in the field, I'm seeing some doctors perform an AOMSI / impairment rating the day after the accident. You cannot do that. Now, if you want to compare uh, time of the injury vertebral biomechanics, and you want to use your software, for example, just to see what the alignment's like, to see if AMSI is present at the beginning, I get that. That's okay. But you certainly aren't going to translate that into an impairment rating because you haven't undergone any treatment yet. You haven't undergone any rehabilitation and stabilization yet. You have no idea what the outcome is going to be of this patient. So you're not going to bill, hundreds of dollars for an initial assessment. You have to wait till they're at MMI to do an impairment rating and a bona fide AOMSI ligament injury analysis report that you're going to submit. Because doing the report at the beginning, again, while it gives you status at the start of care to compare to later, yes, there's value in that. You're not doing a full-blown analysis as it relates to impairment or to permanency, right? So they say that the terms stable, rateable, all of that is the same thing as MMI. So you can't be rateable unless you're at MMI. You can't be stable unless you're at MMI. It can't be permanent unless you're at MMI. So let's say there is no medical treatment, no chiropractic treatment. You're at an MMI point. Let's say it happens to just be at 1 year and 3 months. So after a year of care, you've determined, at the 15-month mark, they're just not improving anymore. They're stable. Okay, now you're going to do it. Let's say that happens at the 9-month mark. That's okay. If they've flatlined, for a couple of months and you've stretched your care out where there's been no care for a whole month and they're stable, maybe you do that for 2 months and every 30 days you're kind of following up. You might even wait 90 days and then you do a follow-up. That's your call. That's your clinical expertise making that decision of when they're at MMI. But you need to confirm it. You need to document it in your notes when they achieve MMI and how you arrived at that. And that gives you the green light to go ahead and now do a bona fide AOMSI analysis. But what if in your determination of MMI, what if you decide that this patient could be a surgical candidate? They might have a radiculopathy and you've already done an MRI and there's a clear, massive lateral prolapse of the disc. And you've done everything you can chiropractically and you think, you know what, Mrs. Jones, you should consider surgery. But Mrs. Jones says to you, there's no freaking way I'm letting a surgeon cut on me. I'm paranoid about it. I had a relative who did it. They lost feeling in their arm. I am not going to have surgery. Whether it's founded or unfounded fear makes no difference. It is the patient's preference. You need to document that and why surgery or treatment was declined. You should still make sure if it's a surgical case that you've referred them to a surgeon and let the surgeon try to have a conversation. But you need to document if they didn't perform your recommended care plan, your recommended treatment options, or if you were going to refer them to another specialist and they declined, what was their reasons for declining? Let the patient know you're going to document that and say it's okay, it's perfectly allowed. It's not a negative, but you have to document it. Is that the real reason? Are there any other reasons? They might say, well, I can't afford it. Oh, that's a little different than not wanting to do it. So all of those things need to be taken into consideration. You are still allowed to make a determination that they are in fact at MMI. They can be at MMI even though they decline future treatment. Just document it and hopefully it's reasonable. Now we're going to cover one other little topic before we dive into the measurements, and that is apportionment. I've seen this term used incorrectly out in the field as well. So apportionment is discussed in the AMA guides, both the 5th and 6th. And apportionment, as it relates to the AMA guides, is specifically for one thing, and that is for pre-existing impairment or a pre-existing condition that contributed to the current injury's impairment. What I mean by that is, let's say somebody was in a car accident 10 years ago and they were given an impairment rating, a permanent impairment rating of whatever, 5%. And now you've arrived at a 14% impairment rating. Then, and it depends what addition you're using with your 14%. Are you using the fifth, the same one that was used on her 10 years ago? You want to make sure you're using the same addition for the apportionment. So you would subtract the 5% from the 14% and say they have a 9% impairment based on the fifth addition, and you use both, use the same addition on both. However, what if you're using the sixth addition and your state now requires the sixth addition? Well, you need to try to match up the additions, and you might want to go back and you just have to describe why you're using the fifth, even though your state jurisdiction says, well, you really ought to use the sixth. Or what you do is you go back to 10 years ago, you get the records, and you reapply the sixth edition to the 10-year ago rating using the sixth, and say, well, in the sixth, they wouldn't even have had an impairment possibly. Or maybe it was 1%, or maybe it was 5 using the sixth. And you need to describe that. And then now you're using the sixth present day time with the current injury, and you arrive at an apportionment. Okay. So apportionment relates to pre-existing conditions impacting. Now let's do an example here. What if somebody had an impairment rating on their knee, but nothing on the neck, and you're now doing a neck? Well, obviously there's no apportionment there. The knee has nothing to do with that neck, let's say. Or let's say they had COPD and they had a lung respiratory impairment, and you're doing the neck. Okay, there's no apportionment needed for that, right? Or let's say they had some neck complaints prior to this new auto accident, but they weren't of the nature that they were of a permanent nature. You need to describe that in your narrative, that there were some pre-existing symptomatology from sleeping wrong one time. They woke up and their neck was kinked up, but it is nothing that was resolved. There was no permanency, thus no apportionment is needed. So they do give you some guidance. And do you do a straight up subtraction? Do you just take 10% off of your number? I don't mean 10% impairment. I mean, like, if they had a 20% impairment and you want to take 2% off for something that was very mild, you can do that. I will share this with you. 95% of the time, there's never apportionment needed. It's not required. But I'm just sharing with you, when you hear the term apportionment, that's what it's talking about, because there's some wrong ways to do apportionment. Let's use this example. If a patient had an AOMSI measurement that equated to 19% on relative translation, so we do a flexion view, the C5 vertebrae has shifted forward on the AB ratio. It comes out to 19%. So 19% is not rateable, okay? Because you need to be greater than 20% to be rateable. So 19% is not rateable. And we're talking about not pre-existing, we're talking about today. So you're doing an AOMSI analysis today. So here's the question. Can you apportion this 19% number, this numerical measurement in AOMSI, this percentage? Or let's say you were using the old fifth edition and it was 3.4 millimeters. So let's say they had a 3.4 millimeter, just 1.1 millimeters away from being rateable. Okay, not 1.1 millimeter, excuse me, 0.11 millimeters away. Okay, so 1/10 of 1 millimeter away, so small that you might be inclined to say, well, gosh, they're that close to having an impairment rating. I'm going to apportion it because let's say as a result of that 21%, it would have equated to a 4% impairment rating. And in the fifth edition, it would have been a 25%. And you decide, well, I'm going to apportion it because they're so close, and you lower the amount. Is that allowed? Is that apportionment? No, no, no. When it comes to AOMSI, they're either rateable or they are not. You are not allowed to adjust the measurement. It's a measurement, it's a factual number, and you're not allowed to assign mild, moderate, or severe to the number because the number is the number. You don't get to say 20% is severe, but 19% is almost really, really severe. You don't get to say that. It's a number, period, and you don't get to apportion it. There's no such thing as a prorated impairment rating. The numbers are the numbers, folks. And I'm seeing people incorrectly applying this. So we're going to take a little 3-minute Q&A right now. So if you look at your question mark box in the upper right, you can type in a question. Click on that, enter your question, submit it, and I'll answer those questions. If you need to take just a quick little break, but here's what we're going to dive into now. So we're at the halfway point, and what we're going to do now is we're going to actually go over the exact measurements on AOMSI, the correct way to do it, and then we're going to go over how to arrive at an impairment rating from those measurements. So the fun stuff begins. All right, we're going to dive right in here, folks. One moment. Okay, here we go. Okay, by the way, I went ahead and put up this QR code. You can scan that if you want. By scheduling a consultation and participating in that, you can get a free sample report, a full-blown AOMSI report with references, diagrams, how to do the measurements. It's a complete explanation. So right now we're going to dive into how to do the AOMSI. So we want to first determine what addition are you going to use? Well, you need to know what addition before you calculate your measurements because do you want relative translation or do you want linear translation? So AOMSI is alteration of motion segment integrity. Well, a motion segment is 2 vertebrae, so you'll always use a hyphenated vertebral level, C4-C5, C5-C6. You're never going to say the C5 had translation. It's a motion segment, and it's always the top one that is doing the sliding or doing the angulation, right? So when we describe a motion segment, we're always going to use a motor unit, if you will. You're going to use flexion and extension cervical spine films. Now, when you use x-rays, I've had some people say, oh, can I use video fluoroscopy? It's the same thing. It's just basically a movie x-ray. I'm going to share with you in the new 6th edition guides, they specifically came out and said no. So it needs to be a static x-ray, flexion and extension, and obviously you're going to have neutral lateral as well. So what is the definition of abnormal? I also see so many people use the term abnormal to describe something less than rateable. The AMA uses the word abnormal for rateable. So if you're using the word abnormal, it means it's rateable. So please avoid using the phrase abnormal to describe something that might be 3.4 millimeters. Now I realize 3.4 millimeters on a linear translation or a 19% relative translation might be uh, away from what's considered normal. I'm just sharing with you the term abnormal used by the AMA guides when describing AOMSI is rateable. So we've come up with evidence of injury is the phrase we like to use. There is evidence of injury when you have these um, measurements that are still significant. And the three measurements you see here, relative translation, it has to be greater than 20%. That means not 20%, it means 20.1%. Angulation as a methodology, it needs to be 11.1 degrees, not 11, 11.1. Same thing if you're using linear translation, 3.5 millimeters, it needs to be 3.51 millimeters in order to be considered abnormal. So when we use plain film x-rays on full flexion extension, it's also important to make sure you have the patient at full flexion, at extension. Does that mean um, you need to coach them on proper positioning? Of course you do. You need to make sure you have accurate positioning to eliminate any potential distortion. You want to make sure that they are going into full extension. And as you know, some people just cock their skull backwards and they're not putting their neck into extension. They're putting the skull into extension. It's best on the measurements, it's best for the patient to make sure they're going into full flexion and extension. Okay. So, alteration of motion segment integrity. You see the A and the B, and we're going to go into what does it actually mean? Is it just simply a misalignment of subluxation? No. The whole purpose of AOMSI is to determine ligament injury, specifically the posterior longitudinal ligament in this case. So if you have an anterolisthesis, which would occur on flexion. So on flexion, we're looking to see if there has been a disruption, a laxity, some disturbance allowing for the forward or anterolisthesis slippage on the flexion view. It also can result in widening of the posterior disc. Now, when we take a look at extension, the extension view, we're going to have the ALL, the anterior longitudinal ligament, that has potential disruption. And there's also widening of the anterior disc. We're not saying there's a bulging, we're saying there's a widening. It's biomechanics, folks. And again, this book right here, Punjabi and White, Clinical Biomechanics of the Spine, this is the main reference. I went out and bought the recent version. I paid like over 200 and some dollars for this book. I don't even know if it's in print. I got it off of a used Amazon uh, account. Anyway, it goes into great detail, and that's what the AMA's primary reference source is for all of this. And it's interesting when you read it. It's kind of eye-opening, but it's interesting when you read it. They showed if there is 3.51 millimeters or more, there is a disruption of the ALL or the PLL, whether it's flexion, respectively, or extension. There is clearly a disruption. As a matter of fact, in their cases, it was total disruption. So there is some magic to the numbers that could a 3.4 millimeter or could a 19% Relative translation indicates some laxity or micro tearing, such as the first image on the far left. Certainly, but the study didn't look at that. And we don't have scientific literature to say that. We can arrive at that conclusion, but there isn't published literature to state that exactly. Now, there is other literature that the AMA guides do not quote, and you could rely on that, but you can definitely not use that other literature to arrive at an impairment rating. Definitely not. And then you have to separate the two. You can't say, well, based on the AMA guides, I'm saying this, when in fact you're quoting some other resource unrelated to the AMA guides. We'll get more into that when we get to the references. The good news is that the AOMSI analysis is present in the 5th and 6th editions and the 6th 2024 edition. However, here's the difference. How you measure translation is different. And I mentioned earlier about the AMA Guides newsletter. The newsletter made corrections to the 5th. Even though it's not in the 5th textbook, they made corrections. And they went on to state that when you're doing these measurements for AOMSI, these measurements right here in front of you, the angulation method and the relative translation method, these are the most scientific methods to use when determining AOMSI. They never said you can't do linear translation. You can. They do allow for it in the 5th only. In the 6th edition, you are not allowed to use linear translation. Even if you go back to 2008, in the 6th edition, 2008, when it was first published, they eliminated linear translation, which was the 3.5 millimeter measurement. They eliminated it back in 2008. Well, when some corrections came out in 2019, mostly related to the 6th, but they mentioned the 5th, they stated the most scientific method as those two right there. So here it is, folks. Relative translation is in both the 5th and 6th. Linear translation is in the 5th only. Angulation 5th and 6th. So if your state or your jurisdiction requires you to use the 6th edition in PI cases, well then don't even consider using linear translation because that's a 5th edition only measurement. So let's get into angular motion. We're going to show you how to do it. When we take a look at C5 in this case, take a look at C5 there, okay, and C6, that motion segment clearly has a sharp angle there, right? So what we're doing is we're measuring an angle at each segmental motion unit, and then you're going to compare the angulation measurement above it and below it. And if there is greater than a difference of 11 degrees or more, 11.1 degrees or more, it meets the definition of AOMSI. So let's kind of show you how we do it. And just for reference, you only do angulation on the flexion view only. You don't do it on extension. Flexion only, clearly defined and corrected in the errata versions of both the 5th and the 6th. So what you're going to do in this case is determine if there is an irregular motion on the flexion radiograph greater than 11 degrees. And the way you perform it is by putting a line on the inferior end plate. So notice on the diagram, the line is on the inferior end plate. So you go to the posterior inferior corner and the anterior inferior corner, draw a line, extend it forward, and do that on each of the vertebrae. And then you see the A, B, and the C, the angles. So you're going to measure that angle where the two lines meet. Now, when you look at B and C, you can see C isn't even going to be, it's going to be, that one's going to be a negative, right? B, um, it's going to take a long time for those two lines to meet. But guess what? The computer, if you use a computer and you use a computer assisted calculation algorithm, it'll do the calculation for you. I remember back in the 90s doing this manually. I remember having to go off of the x-ray to come to a point. It was crazy. It drove me crazy in the 90s, in the early 90s when we didn't have computer assisted calculations. So just by you drawing the point, just by you placing the points on the inferior end plate, the calculations will all be done for you. Now let's talk about relative translation. This is more of a translation, a forward slippage on flexion, a posterior slippage on extension. And this is calculated as a percentage. I call it the AB ratio. Let's zoom in on this here. This is used in both the fifth and the sixth. So the AB ratio, or the percent relative translation is described in the fifth, but the error they made in the textbook of the fifth, the diagram used the 3.5 millimeter and they never diagrammed except in the subsequent print versions. So the fifth edition came out in 2001, right? They did have, some other printings where they made a correction early on, but they're not even making that anymore. So they relied on the AMA newsletter to make the corrections, and they shared the substitution of the diagrams on how to do the measurement. So the fifth and sixth have relative translation, and this is how you calculate it. So you're going to go place a point on the vertebrae at the bottom, the inferior vertebrae. You're going to put it at the posterior superior corner of the vertebral body. You see the point there, the red dot. And then you're also going to do the same thing on the inferior end plate of the one above. You'll draw a line uh, that is across the end plate on the inferior vertebrae. But notice B. What is B? So this is where many of you have possibly made an error. Many of you have been using the measurement of B as the inferior end plate. So I'm going to do a little highlight here with a laser pointer. And some of you have been using this line here, the inferior end plate of the superior vertebrae, as your B measurement. And that would be incorrect. You have to use the mid-sagittal vertebral body. Now, in this example, see how the vertebrae scallops inwards? It scallops inwards, which if you go all the way out here to the point and you use this measurement from this corner to this corner for the B measurement, you would be incorrect. You would be having a wrong outcome. But if you go from the end plate, the vertebral body, to the posterior portion of the vertebral body, and that is your measurement for B, your A is based on the right angle coming down from this line, and this line A is in the middle here. That is how you determine the A and the B. I've got the scientific description here to the right, and you're going to do an AB ratio. Okay, you're basically going to divide A by the superior vertebrae's mid-vertebral body diameter, which is the B, and you're going to come up with a percentage. And if that percentage is greater than 20%, they meet the criteria for AOMSI. They meet the threshold. Okay. It can't be exactly 20, it has to be 20.1 or higher. And that is what you call relative translation. So let's take a look now at linear translation, which is fifth edition only. Well, linear translation, quite frankly, is almost the same. It is for coming up with A, and basically linear translation only uses the A component. It doesn't even involve a B. So this is described in terms of millimeters. So A is a millimeter measurement. B is also a millimeter measurement, but when you come up with the AB ratio, you're taking you're taking the A divided by the B to come up with a percentage. Here in linear translation, it's described in millimeters. And this is where you need to be greater than 3.5 millimeters. Okay. And if it's greater than 3.5, then you meet the criteria for having AOMSI if you use the 5th edition. So the challenge becomes, well, do I want to use linear or do I want to use relative translation? Well, I'm just going to tell you straight up, folks, linear translation meets the AOMSI threshold way easier than the relative translation. So what are you going to do? You going to do both? You could. I'm not saying that, but I know people in their reports, and we allow people in our reports to do all three. Well, obviously you're going to do angulation because that's the same in the 5th, 6th, and 6th 2024 editions. Angulation hasn't changed at all. It's only the translation that has been upgraded to the more scientific method of using relative translation. But there's nothing wrong with you saying, hey, the linear translation model meets the definition according to the 5th edition. And there you go. You can do it. It's not prohibited. Is it the best method? I don't know. Let's talk about the points now. So if you look closely at this set of extension and flexion x-rays, you'll notice there's 6 dots, red dots. Look closely. There are red dots on these vertebral bodies. And why is there 6? You might have thought, I thought I only had to do 4 dots on the 4 corners of the vertebrae. The reason you're doing the 2 dots in the middle is to come up with the B, the exact mid-level sagittal diameter of that vertebral body. So when we look at this example, most of these vertebrae are fairly square, if you will. But if you go down to C5 and C6, there's a little minor scalloping. But you know what? It's a millimeter or two. And that millimeter or two could be the difference between being AOMSI or not. And folks, remember, you're being objective. You're not being biased. You're placing that point, and you can zoom in on your digital x-ray software. You zoom in so you can blow this vertebrae up. You can blow it up and place it on that cortex of that vertebral body. So here's the neat thing. How do you determine where that mid-sagittal line is? Well, here's the beauty. Let's show you kind of how this is done. Okay, so let's just watch this point placement here. So we do place some points at C2. Now, I'm also placing points here at the spinal laminar line. You don't need to do the spinal laminar line, but I like to look at potential canal stenosis to get a measurement there because stenosis is one of the components inside the AMA guides that can lead as a complicating factor. So once you place the points, then the software does the calculation for you. But what I want you to notice as we go on each particular vertebrae, a dotted white yellow line appears at the mid-sagittal vertebral body diameter. So it calculates for you. It takes a measurement from the superior end plate and a measurement from the inferior end plate, and it calculates the exact mid-level vertebral body line so you don't have to guess. So the line on each vertebral body for the mid-sagittal line is there. You just have to place it on the cortex of the vertebral body in case there's scalloping or bulging of the bone going on. So once you place that on there, you now have all you need for all your calculations. So that's all you do is place that. So let's move forward here. Let's take a peek and see what the results are. So once you have the points, so here's what I like to do. I always liked to do this analysis at the beginning of care. Now, I don't create a report. I don't print out a big report. I just do it in the software. So I don't even move forward with generating the report. So in your software, it gives you the numbers. Now, on your report, it doesn't place these numbers on the image. It gives it to you in a graph or a chart, which is more easier to read than this. But for your own personal edification, your own personal look-see, if you will, to see, hey, is there AOMSI present, or is it you know something of a evidence of a ligament injury? And you can just see here. So when we take a look at this, you look a little closer. It's got both the percentage listed as well as the millimeters. So you take a look, there's a 2.7 millimeter. Okay, so it's not AOMSI rateable for linear translation, it's 2.7, but it's significant. And then you've got your percentages, which are nowhere near um, the 20 mark. And then when you take a look at uh, the spinal canal stenosis, there is none. So my point is, it gives you valuable information to go ahead and place those points at the beginning, but you're really going to do your report when they achieve MMI. And then, of course, you can also look at angulation. So you can take a look at the numbers here. So what do we need to avoid when we do AMSI? You can't have poor quality films where it's fuzzy, where it's hard to make out the end plates. You can't use fluoroscopy. You can't use MRI. The end plate landmarks need to be visible and consistent. You'll notice we actually do use the inferior border of C2, and we do use the superior end plate of T1 so that you can properly do angulation. Now, a lot of times people's shoulders cover up T1. You can make a best educated guess on that because C7 T1 down there at the C7, there usually isn't angulation at that one, but it's important. And if you skip one, okay, then it wasn't in your analysis. Then there's no impairment. If you can't do it on T1, then C7 isn't going to have any type of impairment. So now let's show what's wrong here. This is a mistake. Let's see if you can point it out. Somebody type it in. I'll send you a free report. Okay, what's wrong here, folks? Let's look at the degenerative changes on down by C6. Let's look down here. See these points? Okay. These bone spurs change the shape of the vertebral body. So the point placement here is technically wrong. Could be wrong. Now, does this line that goes from the anterior inferior corner to the posterior inferior corner, is that a straight line? Does that change the location? Are you allowed to put the point inside the bone spur closer to where you might see a uh, more reliable anterior cortex? Yes, you are. The AMA Guides discusses this. The AMA Guides newsletter, and I've said this for years. I'm glad I read it in the newsletter recently. Uh, they had an article on this that you have to be careful when there is significant degenerative changes. You're not going to the tip. You know, we've all seen bone spurs that perhaps come way out to the front, and you can't be putting a point way down on a teardrop bone spur. So you have to use your clinical experience, your evidence base, your best guesstimate, your experience on where you're going to put that point. And again, You're doing this to be objective, unbiased. If you did put it way out on the point, it actually probably results in an AOMSI. So by you moving it back was actually less favorable to the patient to some degree. So what I'm trying to tell you here, folks, is you have to use your best judgment on where you're going to place the points. And this example of an x-ray with these points, if you go down to, let's see, 3, 4, 5, 6, 7, go down to C7, the last full blown one there. You see how scalloping occurs there, or even C6 on the anterior portion. You see why when you calculate the AB ratio, how the point of the mid-sagittal line could be indented because it's not a perfect square. This doesn't mean you're supposed to create a perfect square, folks. I'm not representing that to you. What I'm saying is use your best judgment because like go take a look at C4, the posterior C4. Even though that vertebral body morphs a little bit to posteriorly, that is an accurate point placement in my opinion. That's okay on C4. And because it isn't a significant deviation, it's a solid line of the cortex. It's when you start getting into spurring, or let's say there's a compression fracture and you've got a protrusion of bone going on. So you have to use your best judgment on these point placements. And here's the neat thing. You can run the report based on your best placement. And let's say that level that you questioned came out with a positive AOMSI. You can go back and move just one single point and then go rerun it. It'll take you 10 seconds and rerun the report and see what it shows now. Um, and again, you have to be objective. You have to be um, unbiased in your processes here, okay? All right. So let's just kind of review for a second here how this works. I'm going to show you on an extension view now how the point placement works. And the tooltip that you see tells you where to put the point. The tooltip says, C3, posterior inferior, or it tells you the mid-sagittal line anterior, mid-sagittal line posterior. So you're always guided where to put the next point so that the algorithm of the computer-aided analysis, and you get credit for using a computer-aided analysis. You've heard me use that term a couple times, CAD. It's in the CPT codebook. And when you use that, there is greater value on that report. So let's dive into impairment ratings as it relates to AOMSI. So we've got the 6th edition, and as you know, we're going to use the 2024 version of the 6th edition because it's the most recent. It's considered the preferred method, and it's the easiest method other than the 5th edition. The only reason the 5th edition is easy is if you're just doing AOMSI 25%. If you're going to go do the 5th edition for the other full body, true whole person impairment, because they have shoulder problems, they have all these others, it's complicated. The 6th edition is diagnosis based. You slide your finger down and you arrive at a number and then you combine them. So here's the steps before you do an impairment rating. Do you have an accurate diagnosis that is clinically relevant to this injury? So let's say somebody has an ACL repair, they have a total hip replacement, but all that stuff was before the accident. I know some chiropractors out there like to list 20 diagnosis codes. That's crazy. Put the clinically relevant diagnosis, let's say it's disc herniation from this car accident with radiculopathy. Let's say it's AOMSI. So you're going to have a ligament injury diagnosis. Let's say you have a diagnosis specifically related to this auto injury. That's what you got to keep it to. Once you've got your diagnosis list, great. Then you need to confirm maximum medical improvement. Are they at MMI? Have you confirmed it? Have you documented it? And then now we're going to go to the DBI table in the 6th edition, the diagnosis-based impairment table. And then we're going to go down that table and determine which row, class, and grade applies to your patient. And then boom, you've got the number. So let's do it. So in the 2024 version, uh, it is standardized. They have done studies on it saying that it doesn't actually result in a huge variance from the 2008 version. However, I will say it does when it comes to the spine uh, as it relates to AMSI. So here's the things you got to have. And this has to be in your notes, folks. It has to be in your overall narrative report. This is not in your AMSI report. This is in your like your cover sheet or your summation report. You need to use these terms: the clinical history, the physical examination, and relevant clinical studies. And one of the relevant clinical studies is flexion extension X-rays. Okay, you might have others. You might have an MRI. You might have a nerve conduction velocity test. Your physical exam might have a Sperling's test. It might have what they call specific individual elements. What are the details of the history, such as the mechanism of injury? What are the details of the physical exam showing radiculopathy, range of motion showing potential instability? The history also has the residual complaints. You've got your functional rating index. You've got your questionnaires. Uh, you've got your study reports. And one of your studies that you might have is the AOMSI analysis report. Maybe you did it. Maybe you had a radiologist do the AOMSI measurement for you. And by having the radiologist do it for you, now you have a truly independent person doing it. That's okay. But you are the one who's going to do the impairment rating. You are the one who's going to confirm the AOMSI measurements. You will confirm it. So let's start with the clinical history first. The clinical history, guys, is actually more detailed than we think. You have to include your patient outcome measures, the PROMs, right? Your various questionnaires, your visual analog scale. It's all focused on function, right? Uh, the 6th edition is heavy on diagnosis, heavy on function, right? And then what they mean by the natural history of the condition, what they mean is the mechanism of injury. You need to describe and confirm that the mechanism of injury relates to their current symptomatology, their current diagnosis. If you don't say that, a smart attorney can throw out your entire impairment rating. I'm going to say that again. If you do not confirm in your notes that the mechanism of injury is consistent with with the diagnosis and the residual symptoms and history of this patient, you've got to mention that. Okay, so I'm going to go back to our steps here. We've got to have the diagnosis clearly identified. So in the clinical history, the mechanism of injury, if it doesn't align, this is straight out of the AMA guides. If the mechanism of injury does not align with the diagnosis or it contradicts the clinical history, like it doesn't make sense why they would have this complaint, then determining an impairment rating is not feasible. It's a key element. Have to go over mechanisms of injury. Then the functional history is also critical. You have to go over ADLs. You must administer something like the pain disability questionnaire. You need to administer uh, any of these that I've got listed up here. All of these are mentioned inside the AMA guides. You certainly don't need to do every one of these because they're repetitive. So when you take a look at the Quebec Back Pain Disability Index, the Oswestry, the neck pain disability index. All of those are acceptable. They do seem to put a little bit of an emphasis on the bottom one, the PDQ, the pain disability one. Now, the thing we have to be aware of here is you score these things. Now, I've always said mild, moderate, severe doesn't exist when it comes to AOMSI, but mild, moderate, severe does exist when it comes to functional indexes or PROMs or those kinds of scoring. Then when you go to the physical exam, you really need to make sure you've got Sperling's test and provocative testing that leads to um, evidence of radiculopathy, because radiculopathy is a huge, huge method that they've put a major emphasis on to add to the impairment rating. And then the clinical studies, some kind of imaging, electrodiagnostic tests, etc., and certainly your flexion extension views, which is your AOMSI ligament injury report. And then these specific individual elements for each of the three, these are examples. They might have a deformity. It could be skin sensation changes. You're obviously going to do a full neurological exam. I'm a diplomate in neurology and chiropractic neurology and have a fellow by the International Academy of Chiropractic Neurology. Bone up on back in the 80s and 90s, it was all orthopedic tests. Everything now is all neurological. The emphasis is on neurological. Temperature changes, skin sensation. Um, do they have weakness? Are the reflexes impacted? Do the pinwheel test? If you can document a dermatome or myotomal changes, if you can show that there's a potential nerve root involvement more than just taking oblique views, for example, for an IVF narrowing, you've got to have neurological tests. Now, they usually want a nerve conduction test, but you'll see here on some of the examples I'm going to go over with you in just a second here, how radiculopathy can certainly add to the impairment rating. So let's dive in. Even though we've stated the 6th edition 2024 is the gold standard, I'm going to go backwards to the 5th edition. A lot of you like to use the 5th edition. It's okay. Like in the software that we provide in ChiroSite, we allow you, the user, to choose the 5th edition or the 6th edition or both. So you can do both, and you can have both results in your report, or you can just do the 5th only or the 6th only. So let's go to the 5th. Easy peasy, page 392, table 15.5. If AOMSI is present on either angulation or any of the translations, because it's 5th edition, so you can do relative translation or you can do linear translation. Let's go straight to category 4. So you see my mouse going around here, I think. Category 4, it's a 25 to 28%. So what does that mean? If AOMSI is present at just one level, I'm not even going to read the rest of it. You automatically qualify for 25 to 28%. Done. Game over. So you have to mention you're using the 5th edition, page 392, table 15.5, category 4, the DRE method, which is different than the DBI method. This is the DRE method, diagnosis related estimates. And you qualify for 25. Well, how do you go from 25 to 26 to 27 or 28? How do you decide? It's other elements that you can go up to 3% more than the 25. So let's say they do have radiculopathy present. Let's say they do have significant residuals. Let's say they score really high on the functional rating indexes. You could add, and it's your opinion, it's your clinical experience. You could say, I'm going to give them a 27% because of these reasons, or because I'm co-treating, they are at MMI, but they have to take medication. They're on opioids, God forbid, right? And they're taking opioids. That probably won't look good, but anyway, It's another thing indicating the significance of that allows you to go up a point, 2, or 3. Most doctors I see out there, they just pick the 25 because there's no argument whatsoever. They put the minimum down. But I'm going to say grow some and flex your muscle. And if there are other significant findings there, give them a 26, 27%. Okay. So that's fifth edition if you want to go that route. Now we go, this describes it here. Other complicating factors could be a fracture. Let's say they have a stress fracture in there. Let's say AOMSI was 5 millimeters. It was uh, much beyond the threshold, far beyond the threshold. Those could be reasons to give it an extra percentage point, right? So now the sixth edition 2008 version. So in the past, until December 2024 came around, this is what we were using. And basically, if AOMSI was present at a single level, okay, I'm at the 4 to 8% column, then there were variations, and this is where it got complex. This is why they came out with the 2024 sixth edition, because you had to go to a table for physical exam to move it up a point or subtract it. You had to go to a clinical study to move it up or down. So to determine, is it 4, 5, 6, 7, or 8? And then here, you could go to 9 to 14 if radiculopathy was present. So then you're in the 9 to 14 category. So here's what was happening, folks, and here's the changes. They bundled radiculopathy in these 9 to 14 and 15 to 23 percentage categories, or they had multiple levels, they had disc herniations. They bundled the diagnoses together for you to use this number. So here's what changed. So we're not even going to use this anymore because it's not viable. Okay. I'm not going to get into it. I'm just letting you know this is part of the reason they canned it, is because it was complicated to arrive at what number in that range. So the new sixth edition makes it crystal clear. And I said at the top of the hour, you weren't going to be happy. But here it is. I'm the messenger, folks. So here we go. Cervical AOMSI associated with instability. This is straight out of the guides. You're going to go to chapter 17, your class 1, level A. You get a 4% whole person impairment if they have some residual symptoms, so they're complaining. It's consistent with the mechanism of injury, the physical exam. It's consistent with the diagnosis. The physical exam is consistent with the diagnosis. Okay, that's all easy. You wouldn't even be doing an impairment rating if that wasn't the case. And then here it is. Flexion extension radiographs, one of the following, either relative translation or angulation. Angular motion is AMSI is evident, greater than 11 degrees or greater than 20% on relative. If AMSI is there, boom, automatic 4%. Now, some of you might say, well, is 4% significant? Yes, it is. The fact that anybody even qualifies for an impairment rating is significant, and it adds to the value of the case. But now here's where we're going to go, folks. We're going to add some numbers to the 4%. Okay? 4% is the easy man's way out. Okay? If AMSI is present and you've made sure that the diagnosis, the mechanism of injury, they're at MMI, you've confirmed all those things. You look at the x-ray, it's crystal clear. You attach your AMSI report. In the report, you can say, this patient qualifies for a 4% whole person impairment rating according to the 6th edition, 2024 edition. Now, what if you have a radiologist do this for you? What if you have a radiologist perform it for you? Is the radiologist going to do your impairment rating? Absolutely not. The only way a radiologist can do an impairment rating is if they actually do a complete records review, not just your records, but the ER. They look at the clinical history. They look at all your exam findings. Radiologists aren't doing that. So a radiologist, if they're not doing that, cannot issue an impairment rating. What a radiologist can do is provide you with a true independent AOMSI assessment, and they can state the patient is eligible for an impairment rating. And then what are they going to do? The radiologist is going to qualify it by saying, as long as the patient is at MMI, as long as the patient's diagnosis and clinical history is relevant and confirmed to match the diagnosis. So they're going to basically say, you need to do all the things we've been talking about. You, the doctor, need to do that. And then now you have your AOMSI number, your measurement, and you go in a supplemental report or a summary, you're going to make the AOMSI report a supplemental report to your narrative report. And you're going to say, I confirm the findings of the radiologist and agree with the findings and impressions of the radiologist per the radiologist, and then put their quote, this patient's eligible for 4% because at the C5, C6 motion segment, they had a 22% relative translation finding, which according to the AMA guides, blah, blah, blah. You explain it out. Now, let's talk about how do we get that number higher? This has nothing to do with the radiologist now. This is all you. If there is a compression fracture, a stress fracture, even a spinous fracture, the fracture doesn't have to be on the vertebral body. If there is a fracture from this injury or there is a radiculopathy, you can combine an impairment for those things with the AOMSI. You can't combine both radiculopathy and fracture to the AOMSI, just one or the other. So here's the set of rules for the spine. So cervical radiculopathy is only rated in Chapter 17, the spine edition. Spinal fracture is only rated in the spine chapter. AOMSI is only rated in the Chapter 17, the spine. Myelopathy, now we're getting into neurology, is only rated in Chapter 13. I'm bringing that up because let's say you've had MRI and they've got spinal cord involvement and some other neurological findings unrelated to radiculopathy, you may have to bone up on Chapter 13. So as we go on here, let's take a look. The definition of radiculopathy. It's the spinal nerve root, just so we're clear. That's why I highly recommend oblique views. That's why I highly recommend Sperling's test. Sperling's test is mentioned in numerous locations of the AMA guides, so they love that test. And then you want to do the neurological evaluation. Is there radiating pain? Is there numbness? Is there tingling? Is there weakness? Do the muscle tests. Do the pinwheel, the pinprick. Find something that is different from right to left and follows a dermatomal or myotomal pattern. Do the reflexes, okay? Don't just have symptoms because it won't give you an additional rating. You have to have some objective evidence. And I get some of those tests are a little subjective, but we got to have them and then document them. So each nerve root that you're testing, it's not going to be good if they've got, the fifth digit sensation and then the first digit has this. It's got to all be in, a nerve root to really boost it. So here are the possibilities for radiculopathy for any nerve root, whether it is C4, C5, C6, C7, C8. Any one of these nerve roots could have a 2%, 4%, 5%, all the way up to 18% So radiculopathy is weighted very heavily. So here's what they did in the 6th edition, 2024 edition. They lowered AOMSI, but they boosted radiculopathy. They're putting more emphasis on radiculopathy as a result of the injury. So let's do a couple examples. I picked 2 examples. Here's an example of a 5% radiculopathy. So I'm not even talking about AOMSI right now. So if we go down, if they have residual symptoms, the mechanism of injury is consistent with vertebral nerve root injury. There's a sensory deficit, sharp, dull perception, decreased sensibility, and you need one of the following is all, just one, either electrodiagnostic or MRI or a surgeon's objective verification that there is a potential intraoperative lesion at the C5 nerve root. So as long as you have one of these and you have the above, that is a 5% impairment. So remember this, we're going to come back to it. Let's do a 14% impairment based on radiculopathy. So on this one, they need the same mechanism of injury consistency, the accurate diagnosis, and then on the physical exam, you need 4 of the following. So you've got 5 bullet points here. You need 4 of these 5. You need a sensory deficit, sharp versus dull. You need a Sperling neural tension test, positive, reproducible. You need a motor deficit of at least 3/5 on muscle weakness at some point of the upper arm. You need atrophy, or you need asymmetrical diminished C5 nerve root reflex, the biceps reflex. So they spell it all out for you. You need 4 of the 5. And then you need one of these, same as before, either MRI or an NCV. And if you have that, they get a 14% impairment. Okay, so how do we combine these impairments together? So as we said earlier, radiculopathy can be combined with a fracture, or radiculopathy can be combined with AOMSI. It can also be combined with myelopathy from chapter 13. So when you combine impairments, the other thing that they made easy is they already converted everything to whole person impairment. They're not putting it into regional impairments where then you have to, it was complicated in the 5th and 6th 2008 edition where you had to go do an impairment rating for the hand. The hand went to the upper extremity. Then you had to convert the upper extremity to a whole person. It started getting complicated. They simplified it here for the spine, super easy. They're all in whole person and you add them together. Now, how do you add them? I used a bad word. I shouldn't have said add. You combine them because it's not 1 + 1 = 2. It could be 1 + 2 = 1. So here's how we do it. We go to the combined values chart. This is in your digital version. This is actually a 3-page combined values chart. I just have the first page here. Why don't we blow this up here just a little bit, okay? And by blowing it up, let's use the examples of radiculopathy. So you always take the highest number first. So let's use the 14%. So you use the left column. So let's go down to 14. Here's 14. Okay, y'all see it? Here, let me do my laser here. Hold on. Let's go to 14. So we're at 14, right? Now we're going to combine that with the AOMSI finding of 4%. So if you go to the bottom and you see down here, we've got a 4. So you're going to go up the 4 line to the 14. And what does that give us? 4 and 14 = 17. Now I know you're saying, wait a minute, 14 + 4 = 18. But on the combined values chart, it's 17. So now they have a combined whole person impairment of 17%. So that is their impairment rating, 17%. 4% from AOMSI, 14 from radiculopathy. Using the combined values chart, it equates to a whole person impairment of 17. Why do they do that? Well, here's why they do that, folks. Remember, 100% means you're dead. Well, you can never get to 100, so they start decreasing the numbers so that it's impossible using this chart to ever go above 100. Okay? Let's do another example. Let's use the 5% because that's the higher number. AOMSI is 4%. 5% on the radiculopathy. And then we go over to the 4 column from down below, right? We got a 4 here. And we go up. And so we look at the 5 and the 4. 5 plus 4, it is 9. Okay? That math actually worked out. So they would have a 9% whole person impairment. So I hope that makes sense. That's how you use the um, combined values chart. So now we're going to go over the report itself. We're on the wind down here, folks. When you do the radiology report, the AOMSI report, it's a supplemental report to your overall impairment report. The AOMSI is one component of impairment ratings. Yeah, you could make it the sole focus if that's all that's there, because let's say a patient doesn't have radiculopathy. Let's say they don't have shoulder, thoracic, lumbar spine injuries, purely the neck, and all they have is residuals and AOMSI. Fine. Then you've got your AOMSI report kind of as your main focus, but I would still do a cover sheet or a cover report with the AOMSI report as your supplemental. So these are all the things that are inside of a AOMSI report. When we take a look at the ligament injury report, because that's really what we're talking about, that report could be as simple as 1 page, 8 pages, or 15 pages. We recommend the 8-page version. So you want to match up your impressions, or let's say the radiologist does it for you and they put their impressions in the report. And of course, in that impression, they will identify the measurements that met the threshold for AOMSI. They'll report on that and they'll say it's eligible, or they'll say it's not eligible, but there is significant evidence of injury because let's say the measurements using other scientific literature, not AMA, but other scientific literature says if it is, for example, above 2.5 millimeters, that is significant evidence of ligament injury, not impairment, but of evidence of injury. So in your language, you want to say you have reviewed the following radiographic images and concluded the following. So you want to say you've reviewed those images. Even if you have a radiologist do this, you want to state that. The radiologist is going to say this too. You're going to say you concur with the radiologist. So you're going to say what version of the AMA guides you're using. You're going to say it was a category 4, DRE, what level, C5, C6, and then you say the specific details are in the supplemental pages of the AOMSI report. And then on your introduction, you want to make sure you've got confirmation that they are at MMI. You want to confirm that it is consistent with the clinical studies, the mechanism of injury, their symptoms, the physical exam, and the patient's functional history. You want to say that you have correlated that clinically. So you meet the criteria to even do an AOMSI report for the purpose of an impairment rating. So I'm just going to kind of give you an example. This is the one pager from a radiologist, right? So they're going to have the typical radiology stuff in the report. They're going to have, at the top, they're going to put the date of the injury. They're going to put the report date. They're going to put the date the x-rays were taken. And remember, folks, don't be using x-rays from the date of injury. You need to take new x-rays at the point of MMI, because what if something else happened along the way? If you're using x-rays that were taken a year ago, Well, then any changes you made from treatment aren't reflected in those original x-rays. So your final impairment report is all based on current x-rays. Then you have your introduction. We go ahead and have the discussion of findings, which lists the details of the measurements and which motor segments are evidence for injury or which ones meet the threshold for AOMSI. Then your impressions, which is a summary of those discussion of findings. They're straightforward to the point. You're just stating the impairment rating and you're stating specifically the levels involved. Now, you'll notice the radiologist here didn't say they have a 25% impairment rating. The radiologist is just saying they qualify for it. So then you would make a cover page stating, I have reviewed the x-rays. I have reviewed the second opinion report that I requested an independent evaluation for AOMSI determination. And I concur with the findings of the radiologist. You can put some stuff in quote, which is attached. I hereby issue a 25% impairment rating, blah, 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 on down the line. But you're going to do a cover report. And then your report needs to have how you calculated it. It's required, folks. You're required to show the measurements. You're required to show how you did it. Give them the diagrams. Here's how it's done. And you use computer assisted calculations. And so you've got that information in there, and then what methods you used. So if you choose that you're doing relative translation and angulation, then only those will show up in the report. If you choose you're going to do relative and linear, well, then linear is going to also show up in the report. Okay. So it's important. I know we're running at the top of the hour here. I've just got a few more slides, but this is important that we understand how to conduct the final narrative report. And I'm seeing here, I'm stuck. Give me one moment. When we come to the references, it's important that on the references, you list the references in the report. And the references need to list the AMA guides. You need to list Punjabi and White. So as we progress forward, it's important that you have references that are accurate and that you know what's actually in those references. So for example, I've got 24 references attached to our report. The 5th edition, 6th edition, 2024, Punjabi and White, AMA newsletter, Lures, and I have other scientific literature to support the areas when we talk about evidence of injury. There is other valid scientific literature that demonstrates how an injury could still be present even though it's not met the threshold for the AMA's AOMSI determination. And so we talk about that and we put those references here in the report, and it helps you arrive at a graph. And like on this graph, we show the AMA threshold, but then we also show a gray zone that other scientific literature supports that there is evidence of injury. And we carefully selected the language here, so you can put that in there. So now we're going to shift to the impairment rating report. This is the narrative impairment summary. All of these components need to be in your summary or in your notes. It's critical that you have all of these components, or a smart attorney can shoot you down. And then you sign that report. This is an example straight out of the AMA digital guides on what they require for the impairment report. And I'll break that down for you here. It's a template. You can get that if you subscribe to the AMA guides. But in a nutshell, it's got the history of the clinical presentation, the functional history, the proms and the oats, results. You should describe mechanism of injury, the physical exam findings, Sperling's test, clinical studies, which is you're going to mention flexion extension x-rays. You're going to mention the supplemental report attached. The AOMSI ligament report is attached. Any potential recommendations that you might have. And then this is an example of how you calculated your impairment rating. All of the sections, all of the nerve roots. It's important that you use some kind, you don't have to use this grid, folks, but all of this information needs to be inside of your narrative report. You got to have the pinprick. If you're declaring radiculopathy, you need to show you did a thorough neurological examination, uh, the muscle test, the reflexes. You've got to show those things, how you arrived at the radiculopathy. You can't just say, hey, they have this. You got to have all the details. You're really telling a story here from the very beginning of mechanism of injury. You're talking about potential pre-existing conditions only if those pre-existing conditions are relevant. And then when you have your report, you add this AOMSI ligament injury report as a supplement to your narrative. And your narrative might only be 2 pages. It doesn't have to be a Bible here. Even though the supplemental report with all the evidence and the measurements, because you're relying on the MSI to give at least a 4%, well, you are needing all of the mechanisms that we described, and it's all already put in here for you. It's already put in here for you. So you want to send the report, you want to show it, you want to go sit down with attorneys, explain it to them so that they know. You probably only have to do this one time, not every time, but once you get an attorney in your corner, you want to show the patient because the patient's going to wonder, why are you billing $395? Why are you billing $525 for this report? Whatever the amount is, I'm not telling you what to bill, but you're going to bill for that. And there's a code for it. And again, you're using computer assisted, computer aided algorithms. And then what does it mean? Well, it means an impairment and it's permanent. So that's why the images with the line drawings on them need to be in your report. It's worth 1,000 words. Okay. But make it look clear. Make your reports look professional. Take the time. All these other findings you might have that you use with the biomechanical drawings in the software, like reverse curve, or you might do Gonstead measurements. All this is done for you. All these lines are done for you. But this is meaningless in your PI impairment report. I'm telling you, it's meaningless if it doesn't contribute to the long-term outcome of the patient. This stuff is for you and educating your patient. This is technique specific analysis for you, and it's great patient education stuff. But there's studies out there showing that when it comes to an impairment rating or AMSI, a reverse curve doesn't add to an impairment rating. So I'm not saying you can't talk about it. I'm saying it doesn't belong in an impairment report. None of this. It's good stuff, but you're going to flood the jury and the attorney with a bunch of gobbledygook when the only thing that means something is the impairment and AOMSI. So be the expert in your community. Show the attorney you got your act together. You know what's going on. So if you're interested in doing a demo of how easy it is to do the AMSI report, or if you want to have Telerad, a radiology service, do it for you, you can have a radiologist do an independent evaluation of it if you're uncomfortable doing it yourself. And maybe it's one of those cases where you do them, but when it's on the line, like it's a millimeter away, Maybe you just want to get a second opinion. You could still do it, but you could confirm it with the radiologist. So if you're interested in that, you can scan this QR code and it'll take you to a landing page to select getting a sample free report, an AMSI report. You can select a consultation. You can select a room design for a full x-ray system. You can do whatever you want. There's all kinds of goodies on that page. And remember, I put a white paper in the materials section in the upper right-hand corner that you can download right now, right from this. Um, so for those of you who want to learn more about billing and coding for the AMSI report, I just touched on it. We're running out of time, folks. I'm not going to be able to dive into it here today, but on August 12th, we have a coding and billing expert, Dave Klein. He's a national coder, certified coder. He's lectured to tens of thousands of doctors all over the country, and he's one of the best. So we've got his insight on the code and the language. And a little teaser right here. There it is. Boom. Computer aided detection with algorithm analysis, physician review, and narrative biomechanical reporting using digitization of radiographic imaging, using augmented data analysis of the cervical spine, lateral, neutral, flexion, and extension imaging views for AMSI determination for potential permanent impairment was performed as a portion of the report, of your report. It was performed as a portion of it. How beautiful is that? That is beautiful language. Dave and I worked on that. It's most of that language, folks, over 50% of it came right out of the CPT code book to best apply for this. And you deserve to bill hundreds of dollars for this report. I know guys billing $700. The cheapest guy I know is doing 195. The majority are in the $300 to $400 range for doing this report. It's valuable evidence to help the patients arrive at a fair settlement, which is the whole purpose of the AMA guides. Folks, I want to thank you. I am going to stay on and answer questions. I know I'm way over time, so I understand many of you might hit the road here, but I urge you to go ahead and scan this QR code, do a demo of the report, and then that'll make you eligible to get an email for a report. Folks, I'm not joking, over 300 hours of my time constructing this report. I looked at every single resource out there and put the best ones in there. Um, it's done the right way. The language has been gone over and over. I've spoken directly with authors of the AMA guides. I've attended their webinars. I've asked them direct questions. Chiropractors can do this. You are allowed to do it. Okay. You don't have to be certified. You just have to follow the rules. And I'm here to help you follow the rules. So thanks again. We at Chirosite appreciate you. We think personal injury is a huge mechanism for revenue enhancement for the chiropractic profession. I'm going to go ahead and start answering some questions now. So let's, okay, here we go. All right, let's see what we got here. I'm going to start at the bottom, those who asked first. What is the time frame? All right, Jason, I wonder if you're hanging around. What about lumbar spine translation? Lumbar spine translation has similar rules and guidelines as cervical spine. I kept the focus on cervical because 92% of AMSI from automobile injuries is cervical spine. So lumbar spine translation happens. Is it from the automobile injury? Depends on the mechanism of injury, right? So when is Chirosite going to have it? It's being worked on as we speak. I'm not gonna. My developers are gonna shoot me with a gun over here. I'm going to tell you after Christmas because we have some cool stuff coming basically over the next 30 days. The new release is coming out, and then the next release will be in January. Uh, can AMSI be used initially to assess the initial severity of ligament injury? Yes. Let me blow this up. And at what degree of injury is the diagnosis ligament laxity utilized? There is no rule in, so remember, the diagnosis ligament laxity is a CPT code, right? I'm sorry. I'm sorry. It's a ICD code, right? It's a diagnosis code. So that's not part of AOMSI. So you get to make your determination on your experience and the scientific literature. And as I mentioned to you, I've got about 10 other pieces of scientific literature that indicates ligament laxity does exist at lower measurements, not at the thresholds that the AMA uses for determination. So you can certainly use ligament laxity as a diagnosis if you have the evidence and you're backing it up. Okay. Someone asked, what about the back, neck, Bournemouth? Hey, that's substantiated. It's good. I shared with you the proms that the AMA listed in their book. Okay, so that's why I selected those. One that I love is the FRI, the Functional Rating Index. That is fantastic. That was created by a chiropractor, but it's proven in the scientific literature, and the Quebec Task Force recommends that one as well, but it wasn't in the AMA guides. What's the best diagnosis ICD-10 code for ligament injury? That'll be on the webinar August 12th. Okay, everybody who's on this call is going to get an invitation to attend that, and we go over diagnosis codes, CPT codes, and description, how to properly bill x-rays, and how to bill for the AMSI report. Can I rewatch this? This is recorded. This will be made available to all of you. You'll get an email, and it'll be available for a year. Chirosite users, it'll be available forever in your training section. But the link you're going to get, it's available for a year. How do I get Chirosite to help make this report? This report is Chirosite's report. 10 minutes of your time, and you have the report. If you want to give it to a radiologist, it is 30 seconds of your time. The radiologist will do it for you. Who do I send my x-rays? Let me read this better. Hang on. Who do I send my x-rays to get a nice report like this that I can send to my attorneys? Then I can sign that I agree with the report. Yeah. So you'll just have a cover report, a cover page outlining the mechanism of injury, outlining the clinical history, the exam, and you're going to mention you took flexion extension views. You've reviewed those, and you have reviewed this report and the methodologies used to arrive at the AOMSI, and I concur with the findings of the radiologist. That report is attached. My recommendation to you guys is you title yours a cover page or summary page to the Chirosite report. We are going to build that template for you. We're working on that. But for right now, just do it yourself because I recommend you have, that Chirosite report's your whole report. That's your report. The cover page is the radiologist because the radiologist didn't do anything on pages 2 through 15. And remember, I only recommend you use the first 8 pages. The other pages are there, fun stuff. I would not submit that to the attorney. It's complicated, unnecessary. Use the first 8 pages, and the front page is what the radiologist is signing, and you concur with that. Who do you send your x-rays to? To Telerad. Click on the QR code to my left, and there's a button when you go on that landing page that says sign up for Telerad. We haven't opened it up to the radiologists yet. That becomes effective September 1. We're rolling that out. September 1, you can use the radiologists on Telerad to do AOMSI reports. Is there an extra charge for the radiologist to do it? Yes, there is, Bob. It's again, we're going to release that on September 1. It's a separate fee for the radiologist to do it. The $14 radiology charge is to just do a standard pathology X-ray report, not an AOMSI. They've got to do all the point placements. They've got to create the whatever edition you're going to check a box. I want the 5th edition. I want the 6th. I want the 5th and 6th. Whatever you're going to check in that what you want in the report, they have to then apply the correct measurements and then the correct references to the 5th, 6th, or both, or one or the other. So they've got some work to do to assemble that for you and put their signature on, but they'll still do it all inside of Telerad to you. Folks, I want to thank you very much. A lot of info. And as you can see, this is high level. This took us 2 hours. So there's a lot more. I'll dive in the future on some advanced other ones, but let's get the billing down so you can make some money off these reports and help your patients. Have a great day, and thanks for attending.